Ever looked at a chest X-ray and just seen a confusing mess of gray and white? It's one of the most common tools in all of medicine, but let's be honest, figuring one out can feel pretty intimidating. In this explainer, we're going to break it all down step by step. We'll give you a framework to see it not just as an image, but as a detailed story about what's going on inside the human body. So let's jump in.
At first glance, it seems simple enough, right? Black is air, white is bone, or maybe fluid. But the real trick, the thing that makes this so challenging, is that we're looking at a three-dimensional person squashed down into a two-dimensional image. Imagine trying to understand a whole building just by looking at its shadow. Everything, the ribs, the heart, the lungs, the spine, is all piled on top of each other. Our job is to learn how to mentally unpack that shadow.
So how in the world do we do that? Well, we've got a roadmap. We're going to start with that whole 2D problem. Then we'll map out the must-know anatomy. After that, I'll show you a technique that all the pros use, a systematic search pattern. Then we'll have some fun and test our skills with a few case files, dive into some key disease patterns, and we'll finish with what is, no joke, maybe the single most important rule in reading any X-ray.
So let's dive right into that first big hurdle. How do we make sense of a flat image of a 3D object? Getting this one concept down is the key that unlocks everything else we're going to talk about.
The key word here, the big concept, is superimposition. Everything in the path of that X-ray beam gets flattened onto the final image. Think of it like a shadow puppet. From the shadow alone, you can't tell if one shape is in front of or behind another. And that is exactly why radiologists almost always get two views. The first is a PA view, which just means posterior anterior. The beam goes from back to front. The second is a lateral view, from the side. The whole goal is to use your brain to fuse these two flat images into a true 3D picture. Okay, so before we can start spotting what's wrong, we've got to know what right looks like, right? This next section is all about building a mental map of the chest so we can turn that jumble of shadows into a landscape that feels familiar.
Let's kick things off with that PA view, the one from the front. Now, before I give anything away, just take a second and look at it. How many major structures can you confidently point out on your own?
All right, just remember, we're looking at the patient as if they're standing right in front of us. You can probably make out the ribs pretty easily, and that big heart silhouette in the middle. The big dark areas, of course, are the lungs, full of air. But what about the finer details? Can you spot the windpipe?
Let's break this down. See this little air pocket at A? That's just the stomach bubble, totally normal. C is, of course, the heart. Now, this bump at D is really important. That's the aortic knob. If that gets too big, it could be a sign of an aneurysm. E is the trachea, our windpipe, and we want to see that running straight down the middle. And G here points to the hilum, which is where all the blood vessels and airways dive into the lungs. This spot can get enlarged with things like infections or even tumors.
Awesome. Now let's flip it on its side and get that crucial third dimension. This is the view that lets us see things that were hiding behind the heart. So, take a look. Can you find some of those same landmarks from this new angle?
Yeah, I know, this one can throw you for a loop at first. It can be a little disorienting. You can clearly see the spine running down the back, the sternum at the front, and that nice curve of the diaphragm at the bottom. But where did the heart go? What about the aorta?
And here is exactly why this view is so clutch. The heart, C, is sitting right there on the diaphragm. The aortic knob is D, but now we can actually see the ascending aorta, J, as it curves up from the heart. The trachea, E, is that dark tube of air. And check out K, that's the right diaphragm. It's usually a little higher than the left, which is perfectly normal because the liver is sitting right underneath it. This side view is what really lets us build that complete 3D picture in our mind.
Okay, so we've got our map. Now we need a way to explore it without getting lost. And here's the secret weapon, really. This is what separates the pros from the beginners. Instead of just letting your eyes wander, you use a methodical search pattern to make sure you look at everything, every single time.
And to make it repeatable and easy to remember, we've got a great little mnemonic, ATMLL. The easiest way to remember it is to ask, are there many lung lesions? We start with A for the little bit of abdomen you can see, then T for the thorax, that's the ribs, the bones, the soft tissues, M for the mediastinum, that whole central part of the chest. And finally the two L's. We look at each lung one by one, and then we compare the two lungs to each other.
So, what does that actually look like? Well, on the left here you see the theory, this kind of S pattern that snakes back and forth to cover all the ribs and soft tissues. And on the right, you can see how you'd apply that to a real X-ray. What you're doing is forcing your eyes to go everywhere, not just to the big, obvious stuff.
This discipline is what stops you from missing those tiny, subtle, but absolutely critical findings.
All right, enough theory. You've got the map and you've got the system. It's time to put you in the driver's seat. In this section, you're the radiologist. I'm going to give you a case, and your job is to use your new skills to spot the clue. Here's our first case. All you know is this: the patient has back pain. Let's look at the lateral X-ray. Use your system. Look at the bones, the soft tissues. What do you see?
Really take a good look here. Scan up and down the spine. Check out the area behind the heart. Is there anything that just doesn't belong?
And there it is. The cause of the back pain is, quite literally, a knife in the back. Now, obviously, this is a wild example, but it perfectly illustrates a dangerous mental trap we all fall into called inattentional blindness. Your brain gets so focused on looking for common things, like a problem with the spine, that it can completely ignore a massive clue it wasn't expecting. A systematic search forces you to look at everything, and it protects you from exactly this kind of error.
Okay, that last one was a bit of a party trick. Most findings in radiology are way more subtle than that. So let's try a more realistic case. There is an abnormality in one of these lungs. Can you find it?
Now, this is where that last L in our search pattern, bilateral comparison, becomes an absolute game changer. Your brain is an incredible pattern recognition machine. So look at the right lung, then look at the left. Go back and forth. Compare the texture, the density. Do you see it now? Right there, in the middle of the right lung, a small subtle nodule. It's faint, and you might have missed it. But when you compare it directly to the clear lung on the left, it just pops.
Let's level up a bit to a slightly more advanced topic, but one that's absolutely fundamental for describing lung disease. See, when something is wrong inside the lungs, it usually follows one of two main patterns. It's either a problem inside the air sacs themselves, or it's a problem in the supporting framework around them. This table lays it out perfectly. In airspace disease, the tiny air sacs, the alveoli, fill up with something like fluid or pus. This makes that whole part of the lung look solid white, and it actually hides the normal lung markings. On the other hand, in interstitial disease, the problem is in the supporting tissue, the interstitium. That tissue gets thick, which makes the normal lung markings look way more prominent and busy. But the air sacs are still full of air, so the lung itself still looks black overall. Let's look at how this plays out on real X-rays. On the left, that's classic interstitial disease. See how the lungs are still dark with air, but there's this busy network of fine white lines, almost like a net? This is really common in diseases like pulmonary fibrosis. Now look at the right. Totally different story. That's airspace disease. A whole chunk of the lung is opaque white. That's a consolidation, classic for something like pneumonia, where those air sacs are just filled with gunk. Being able to spot this difference is a huge first step toward a diagnosis. We've covered a ton: anatomy, search patterns, disease types, but I've saved what might be the most powerful tool of all for last. This is what many people call the radiologist's best friend.
Remember that subtle little nodule we found back in case file 2? Well, check this out. On the left is the X-ray where we found it, but on the right is an X-ray from the very same patient, just 1 year earlier. Now look closely at that same spot on the older film. The nodule was there, but it was incredibly faint, almost invisible. The comparison makes the change absolutely undeniable. Is it new? Is it growing? These are the critical questions that comparison answers for us.
This idea is so important, it's a foundational rule in radiology. The old X-ray is your best friend. Radiologists always look at old films when they can. You should too. This single comparison can help you spot brand new problems or track the ones you already know about. The takeaway is simple. Never ever look at an X-ray in a vacuum if you can help it. Context is everything.
So, there you have it. You've got the foundational tools now. You have the anatomical map to know where you are, the systematic search patterns so you don't miss anything, a grasp of key disease patterns, and the ultimate pro tip of always comparing to a prior study. The next time you see one of these gray shadows, you'll know it's not just a picture, it's a story just waiting to be read. And now you have the key to start understanding its language.